Colon cancer. Anatomy of the colon. So the colon is divided into four parts: ascending, transverse, descending, and sigmoid. So the ascending colon lies secondary retroperitoneally on the right side of the abdominal cavity and moves towards the right colic flexure at the bottom side of the liver. The transverse colon runs intraperitoneally towards the spleen, forming the left colic flexure. This part is attached to the posterior abdominal wall by the mesocolon and is therefore very flexible. The descending colon proceeds downwards secondary retroperitoneally at the left abdominal wall. Lastly, the sigmoid colon is the last part of the colon. It looks like an S-shaped tube that hangs off the descending colon and leads to the rectum.
Colon cancer is also known as colorectal cancer. It is a malignant growth of tumor that begins from the inner wall of the colon or rectum. It basically occurs when any of the epithelial cells acquire a mutation in the APC genes, which are tumor suppressor genes. Then, this mutation leads to the formation of small polyps, which are called early adenoma, so it is not a cancer yet. Later on, these small polyps may develop further, such as KRAS or P53 genes, which leads to the development of colon cancer.
Pathophysiology. The formation of colorectal CA is a multi-step process. Begins with an abnormal growth of tissue known as polyp, precursors to the disease, originating from the innermost wall of the colon. The process of transformation from polyp to malignant disease takes years. Once transformation occurs, cancer begins to spread through the wall of colon or rectum. It can eventually invade blood, LNs, or other organs directly. 95% are adenocarcinoma from the glandular tissue. The disease can be prevented by removal of precancerous tissue.
So the modifiable risk factors are smoking, obesity, a diet high in processed meat, excessive alcohol intake, lack of dietary fiber, low fruits and vegetable intakes. And the non-modifiable risk factors are age above 40, family history, and in addition to hyperinsulinemia, inflammatory bowel disease, including Crohn's disease and ulcerative colitis. So the clinical manifestations are subtle and nonspecific or generalized symptoms, asymptomatic in early stage, persistent or sudden change in bowel habits like constipation or diarrhea, bleeding from rectum or blood in stool, vague cramping or abdominal pain, discomfort, bloating, secondary obstruction, perforation, and bleeding. Weakness and tiredness in advanced stage, iron deficiency anemia, unintentional weight loss, increased liver enzymes, and hepatomegaly and jaundice in advanced disease.
The next topic that I will discuss will be diagnostic findings. Diagnostic findings is all about the signs and symptoms, the entire large bowel evaluation, the colonoscopy, the double contrast barium enema with series of X-rays of the colon and rectum, the CT colonography that detect adenomas at least 6 mm, flexible sigmoidoscopy examines the lower half of the bowel to the splenic flexure, capable to detect 50 to 60%, the biopsy, the during colonoscopy, the ultrasound that determines the depth of tumor penetration, assessing LNs, the CT scan, same as ultrasound, plus the useful in assessing for metastasis, the blood test, the blood count, the prothrombin time, the partial thromboplastin time, the liver function test. Carcinoembryonic antigen or CEA to tumor marker, non-sensitive nonspecific in early stage, usually elevated in metastatic or recurrent colon CA. Normal is 0 to 3 nanograms per milliliter to monitor the recurrence. The next is the screening. A. Colonoscopy or barium enema or CT scan, alternative for individuals who don't wish to undergo or is not suitable for colonoscopy. B. Carcinoembryonic antigen level. C. Fecal screening test. D. Digital rectal exam can detect anorectal palpable mass. Number 1, the fecal occult blood testing or FOBT. Many early stage tumors do not bleed. The high false V rate, sensitivity 33 to 75%, increased sensitivity and specificity when used in combination with test tube. Number 2, the fecal immunochemical test or FIT can be used to replace FOBT, sensitivity to 60 to 85%, specificity greater than 97%, no drug or food interactions, uses ABS to detect globin protein Hg in stool. The next is the staging. Colon cancer use TNM in staging like most of the cancers. Here are the stages of colon cancer. Stage 0. At this stage, the cancer cells are found limited to the mucosa or the wall of the colon and is also called carcinoma situ. Stage 1. At this stage, the cancer cells have penetrated into the mucosa and submucosa but have not spread to any other area of the colon. Stage 2. At this stage, the cancer cells have spread past the colon walls but are yet to affect the lymph nodes. This stage is further classified into 3 substages: Stage 2A, Stage 2B, and Stage 2C. The Stage 3 is this stage the cancer cells have not only gone past the colon walls, but have also affected the lymph nodes, but has not yet spread to the organs. The stage 2 has been further classified into 3 substages. The last stage is the Stage 4. This is the advanced stage to colorectal cancer, and the cancer has spread from the colon walls and lymph nodes to the organs through the lymph nodes and blood.
Treatments for colon or colorectal cancer include surgery, chemotherapy, radiation therapy, and targeted molecular therapies. For surgery, the patient may undergo colectomy or bowel resection surgery, anastomosis, and colostomy. So how it works is that during a coloscopy, if a doctor found a polyp or small cancer cell within a patient's colon, the doctor may remove it immediately and take some tissue samples as biopsies for analysis. On the other hand, if a doctor found a large area of cancer, the patient may need to have a surgical procedure to remove the affected part of the large intestine, which is a procedure called colectomy or bowel resection surgery. In this procedure, the doctor or surgeon may remove part of the patient's colon and or part or all of the patient's rectum. Nearby tissues such as lymph nodes may also be removed to see if cancer has spread there. In most cases, the remaining ends of the patient's large intestine will be reattached, a procedure called anastomosis. But sometimes the surgeon will not attach the remaining ends right away. Instead, a procedure called colostomy may be done to attach the top end of the large intestine of the patient to an opening in the skin of the patient's abdomen, and the bottom end will be closed with staples or sutures. This new opening in the skin of the patient allows solid waste to empty into an attached bag. This procedure or colostomy is usually temporary. Although surgery or surgical procedure is the primary treatment or the treatment of choice for most cancer patients, chemotherapy, radiation therapy, and targeted molecular therapies may also be recommended, either before or after a surgical procedure. Chemotherapy is a treatment that uses drug to attack and kill cancer cells. Radiation therapy, on the other hand, uses high-energy rays to attack and destroy cancer cells. Radiation therapy is often used along with chemotherapy. Lastly, targeted molecular therapy is a type of personalized medical therapy designed to treat cancer by interrupting unique molecular abnormalities that drive cancer growth. The treatment for colon or colorectal cancer depends on the location and the extent of disease. It is important to remember that colon or colorectal cancer is one of the most curable cancers if detected early. So early detection or early diagnosis is important for colon cancer. Prognosis, on the other hand, depends on the extent of the tumor penetration, lymph nodes involvement, and metastasis. So our goal here for localized cancer, for patients with localized cancer, is curative therapy, whereas patients with metastatic cancer is palliative therapy. Surgeries and cancer of the colon or rectum is recommended for patients with stage 0, 1, 2, and 3 cancer. So these stages is where cancer has not yet spread to other organs or has not metastasized yet. So complete surgical resection of the primary tumor mass with regional lymphadenectomy is one of the procedures to be done. At least a 5 cm margin of tumor-free bowel and regional lymphadenectomy. For selected patients with resectable metastasis, surgical resection may be an option. Treatment of cancer depends on the stage of disease and related complications. Obstruction is treated with IV fluids and nasogastric suction, and also with blood therapy if bleeding is significant. Supportive therapy and adjuvant therapy such as chemotherapy, radiation therapy, and immunotherapy are also included. Surgery, again, it is emphasized that surgery is the primary treatment for most colon and rectal cancers. The type of surgery depends on the location and size of tumor, and it may be curative or palliative. Cancers limited to one side can be removed through a colonoscope. Laparoscopy, colostomy with polypectomy or removal of the polyp is the procedure to be done. Neodymium yttrium aluminum garnet laser is effective in some lesions. Bowel resection with anastomosis and possible temporary or permanent colostomy or ileostomy or coloanal reservoir may also be done. So to sum up the medical and surgical management, we have the 4 treatments: surgical procedure, chemotherapy, radiation therapy, and targeted molecular therapy. Among the 4 treatments or management, the surgical procedure is the primary treatment or the treatment of choice for most cancer patients.
Next topic that I will discuss is about pharmacologic intervention. Narcotic analgesic is often administered as patient-controlled anesthesia to manage surgical pain or pain from metastasis. So next is the nursing intervention. Administer chemotherapy agent as ordered. Provide care for the client receiving chemotherapy. Next is provide care for the client receiving radiation therapy. And provide care for the client with bowel surgery.